This is a 40-year-old female patient who presents with chronic cough. As you may have noticed, the abnormality is located on the right side. It's not a primary lung abnormality. Although there is partial atelectasis of the right middle lobe and the right lower lobe, the abnormality is that of an elevated hemidiaphragm. This is better appreciated on this coronal chest CT image, and see how the right hemidiaphragm is really elevated in comparison to the left one. When you see an elevated right hemidiaphragm, think about the cause as being as one of the following. This could be something pulling the diaphragm from above, such as atelectasis or fibrosis. It could be something pushing the hemidiaphragm from below, such as hepatic carcinoma, metastasis, or fluid collections. Something could be wrong with the diaphragm itself, such as weaknesses or abnormal neural supply. By diaphragmatic weakness, we mean congenital weakness in the structure of the diaphragm leading to upward elevation. And such an entity is known as eventration of the diaphragm, which could be partial or complete, and it could be on the right or on the left. Another cause of diaphragmatic reasons for elevation would be acute or chronic trauma leading to complete or partial rupture. Finally, by abnormal neural supply, we mean that the phrenic nerve is not functioning well, phrenic nerve paralysis, that leads to elevation of the hemidiaphragm. For seniors, keep in mind a pitfall for what looks like elevation of the hemidiaphragm on chest X-ray, and that includes a subpulmonic pleural effusion, which is pleural effusion that assumes the shape of the hemidiaphragm between the lung and the pleura, or a mass that is arising from the diaphragm or the pleura that covers it, such as a fibrous tumor of the pleura, metastasis, or sarcoma. Now, this case becomes more interesting if you look at this coronal soft tissue acquisition of the hemidiaphragm. Something that's even more obvious when you look at the sagittal plane. So you probably have noticed that you could see the lining of the diaphragm here, but then you lose it, and at that location you have this funny shape of the liver. There is constriction that looks like a waste of this part of the liver from the remainder of the intra-abdominal component. Here's the coronal image again showing this waist-like constriction. This neat appearance simulates what you see with a cottage loaf bread, and is known as a cottage loaf sign. Such a sign tells you that there is at least partial interruption of the hemidiaphragm with partial herniation of the liver. And this may result due to acute or even very remote trauma. Many patients present very late after their traumatic event. This is the chest X-ray on the same patient 2 years ago, showing that the hemidiaphragm is in a normal location. This was before his trauma. So summarizing what we talked about, elevation of the hemidiaphragm could be due to various causes. The easiest way to think about this is pull from above, such as atelectasis or fibrosis, push from below by soft tissue or fluid-containing abnormalities, abnormalities of the diaphragm itself from eventration, trauma, or phrenic nerve paralysis, and pitfalls on an X-ray such as subpulmonic effusion or masses arising from the diaphragm or close to it. And we learn to look for integrity of the hemidiaphragm and any areas of constriction of the liver. And if you see that, that's a waist-like narrowing, which is consistent with the so-called cottage loaf sign, and it's a sign of at least partial rupture of the diaphragm. Remember that diaphragmatic injuries may manifest at the same time of trauma, but they could also be seen very remotely after an old traumatic insult. Thanks for watching, and more cases later this week. This is a 68-year-old male patient who presented with right upper limb weakness. There's this obvious large area of hypodensity that is abnormal that involves the left frontal and parietal lobes. Before proceeding with this case, let's talk about a few normal anatomical concepts on brain CT. This is a normal CT on a different patient. On a normal CT of the brain, you'll notice that you have two different colors. You have this dark area compared to this brighter area outside. Opposite to what is expected, on a normal CT, the myelinated white matter, which is deep, appears dark, while the gray matter appears bright. The gray matter is composed of the outer cortex, this undulating line that you see here, and the more deep and inner gray matter nuclei, which we talked about before, such as the caudate nucleus here and the lentiform nucleus there. So again, the cortex and the deep gray matter are bright, while the white matter is dark on a normal CT. Now let's go to another example that is abnormal before proceeding to our initial case. This is a 33-year-old male patient who presented with left-sided weakness. So the abnormality is located on the right side. You see this large hypodensity in the frontal lobe as well as another hypodensity in the parietal lobe. Now compare this to the normal left side where you have this undulating normal bright cortex and normal underlying hypodense white matter. The hypodensity on the right involves both the cortex and the underlying white matter, so the distinction between the white and gray matter is lost. If you try to draw a line that continues with the bright undulating cortex, you'll be fine till you reach here where you lose it. Add to that these dark areas of CSF density that we call sulci are lost here because of effacement. They're compressed. Such a finding of effacement tells you that there is at least local mass effect. All the findings that we just described are consistent with what we call cytotoxic edema. So in simple terms, cytotoxic edema occurs when you have swelling of the cells and abnormalities that involve both the gray matter and the white matter. Explains why you have the loss of differentiation between the gray and white matter. And the main reason for cytotoxic edema is a brain infarct. So in this case, this is a patient who unfortunately had an infarction in his right frontal and right parietal lobe. And the reason this young patient who had no known risk factors before had an infarct is the presence of idiopathic cardiomyopathy. And this is his enlarged heart. The echocardiogram revealed a very poor function of the heart with an ejection fraction of 20%. They also discovered a left ventricular clot or thrombus. And this thrombus is the reason he had an embolic event that affected his brain. Now let's go back to our initial case, the 68-year-old male patient who presented with weakness. The abnormality is seen here again as a large area of hypodensity. Comparing this abnormality to what we saw on that poor younger patient who had multiple strokes, you'll notice some differences. The fact that there is mass effect with effacement of the sulci on the left side compared to the right side is going with edema. However, the edema that you see here has different features. First, it's purely involving the white matter. The gray matter, the cortex here, is well preserved. There is no loss of the gray-white matter differentiation. To the opposite of that, the hypodensity leads to a better appreciation of the gray-white matter distinction. If you try to follow the undulating cortex, you notice that there is no disruption of that cortex. Along the same lines, although the edema extends all the way to the deeper white matter areas, the gray matter is preserved. Since the edema involves the white matter and the gray matter is preserved, the appearance is similar to finger-like projections in between gyri. Although this is brain edema, this is a different type of brain edema, a type that we call vasogenic edema. To simplify understanding this type of edema, it's really related to permeability of the vessels. And the main causes of vasogenic edema are neoplasms, infections, and hemorrhage. So what's really going on with this patient? Since we know that this is vasogenic and not cytotoxic, it's not an infarction. For more senior eyes, if you look carefully, you might notice that there is a more discrete area of hypodensity here. Seniors might have noticed as well that there is an area of focal hypodensity in the right occipital lobe. The multifocality and the presence of vasogenic edema in an older patient would raise the possibility of neoplasm, in particular metastasis. Now here's the patient with a CT that was repeated after giving intravenous contrast. It's clear now that you have this large heterogeneous enhancing lesion that is surrounded by a large area of vasogenic edema. We also see that right occipital area of abnormality as well, where you have this faint enhancement, raising the possibility of a second lesion. There's even another rim enhancing lesion in the right cerebellopontine angle. To complete the story, the patient underwent CT of the chest, abdomen, and pelvis, and this revealed a large cavitary right upper lobe lesion. This lesion was a primary lung cancer, which led to metastasis to the brain. So let's revise what we talked about today. On a normal CT of the brain, the white matter is black, the gray matter is bright. The distinction should be clear. Edema that results from infarction is called cytotoxic edema. With such edema, the involvement is that of the white and gray matter with loss of the gray-white matter differentiation. This is in contrast to vasogenic edema, which is increased permeability due to infection, neoplasm, or hemorrhage, which only involves the white matter, spares the gray matter, and has a finger-like projection in between gyri. Importantly, the gray-white matter distinction with vasogenic edema is preserved. A practical point, especially for junior residents, please differentiate between what's vasogenic and cytotoxic, since that's the main distinction on an on-call CT of the brain between what you're going to call a stroke versus other things. Thanks for watching. See you with more cases later.